Hi, everybody. I posted two talks this week. The other talk is the overview of the MDS and the survey process. Also, during the beginning of that talk, I talked about, remember, November 8th, we're going to be doing an evening chat session to look at that past assignment that I gave you on FTAG 329, and we'll focus on that nursing home case that we used in that assignment just to make sure you're having any questions to just assess any issues that you might have came up looking at all these different taped lectures. The other thing is in the syllabus, there's a note about talking about review of the um, assisted living personal care home and hospice. We'll actually talk about those when we'll do our long-term care cases on November 15th. So if you have any questions about that, please feel free to email me. This next talk, we're going to talk about nursing home quality indicators and the consulting pharmacist. Some of this stuff we've already highlighted in FTAG 329, but we'll bring back up. Because we talked about, if you follow the MDS lecture that I had that is also posted, is that the MDS is the minimum data set, and this is doing an assessment of the resident, which gets done initially on admission and then gets done also on a quarterly and annual basis. And from that MDS is identified also from daily charting what are called quality indicators. And these are indicators that help flag if there's possible quality related problems and also prevent poor practices that could be occurring in the nursing home. And these quality indicators also help guide when surveyors come in to see how well is the nursing home doing. Who's interested in quality indicators? Well, it's the state survey agencies, nursing home administrators, insurance companies, quality improvement, and you, the consulting pharmacist. As I've mentioned numerous times, sometimes charting is not always the greatest in a nursing home, and sometimes we have to be very resourceful of how we find our data. And one of the places that is a good resource, besides the minimum data sets, besides the nursing's progress notes, is asking for a report of the most recent quality indicators. The other thing that I usually ask for is also what residents have changed on their quality indicators, because a lot of times quality indicators, although not all of them implement pharmacy can be readily involved in them. And so we're going to highlight and talk about them because there is the issues that go on is that there's incidence and prevalence. And so the incidence is how many new fractures are in the home, how many people are cognitively declined, what is the decline in any possible ADLs, and the prevalence is getting down to the nit and gritty of who fell, who's shown weight loss, who's has some antipsychotic issues, who is showing some pressure ulcer issues. So, looking at the difference between prevalence and incidence, prevalence is a single snapshot in time. So, example, 15 residents have a pressure sore in January. Incidence is two snapshot differences in those over time. One half the residents developed a pressure sore between June and December. It's always important, in my opinion, that a lot of times prevalence is okay to look at a snapshot, especially we got to address those issues of those residents with pressure sores, but we should look at trends too that are occurring in the nursing home and see if this is becoming more of an issue of more nursing education, more changes in the way we handle policies and procedures to help improve the overall incidence of it in a home. So I have a case here, and actually I have the written case of this is actually um, was under all those documents that I gave you. And so this is the exact same case, but we'll use this as our guide. So the case is as the following. We have a 75-year-old Caucasian male, no appetite, does not feel worthy of family visits, not in bingo and activities, swollen in red right buttocks, uses the bathroom 3 times a night, has no bowel movement times 3 days, uses sleep meds times 5 days, has a medical history of asthma, BPH, insomnia, hypertension, hypercholesteremia, osteoarthritis. His available labs and vitals is his blood pressure is 127 over 83. His BMI is he's very underweight, 17.5. He has a TSA score of negative 2.6, a PS of 5. His current medications are the following. Okay, if you look at this resident, and before you even finish this talk, if you want to pause this talk, just take your own time and say, okay, how many issues do you feel could be pharmacy related? And we'll come back to this resident. So let's look at the quality indicators. So the first quality indicator is the following: incidence of new fractures, prevalence of falls. Obviously, if there's new fractures, think about things that the pharmacy might want to think about. What if somebody's fallen? We'd want to evaluate whether or not medications are causing that problem. We've already had the talk, so I'm not going to go into detail. And you had these talks in functional issues in patients earlier on this year, so you can go back and look at your notes on those. But we would want to, as the consulting pharmacist, if we see a person who's at risk for falls, making sure are they on any medications that could put them at risk for falls, and is there a possibility of either doing dose reductions or substituting. We cannot always get rid of all the drugs that can cause falls, but we also can make sure we know nursing is aware of, hey, these drugs do cause falls. The other thing is the incidence of fractures. And so if somebody has an incidence of fractures, the recommendation, might be, to evaluate whether or not what's their bone mineral density. And if you took a look at that resident has osteoporosis based on their T-score. And so I know that you guys haven't had osteoporosis yet. You'll have that next semester. But the goal is we can use different medications to possibly increase bone mineral density. We can incorporate calcium-rich foods or supplements. And there's numerous ways to improve osteoporosis by weight-bearing exercises. The other set of quality indicators, the quality indicator 3, 4, and 5, include the prevalence of behavior symptoms affecting others. So we worry about residents that could become more violent, that could affect another resident. Residents may be screaming out, might be affecting the anxiety of another resident. And so we need to address these behavior symptoms. We do not like to have to use chemical restraints such as antipsychotics, anti-anxiety medications, but if they have to be for a short period of time, nursing should also be looking at other non-pharmacological ways, such as activities that might occupy the resident and keep them, behaviors under control. Prevalence of symptoms of depression. Depression has a high, incidence in nursing homes. Depression can also lead to pseudo dementia, can lead to behavior issues. So treatment of depression. Presence of symptoms of depression without an antidepressant therapy. So making sure that if somebody's showing that they have depressive symptoms, we're treating their depression, and if they're still on an antidepressant and they have depression symptoms, and they've been on an antidepressant for the warranted amount of time that it should now be working, we should be consulting with psychiatry, consulting with the physicians to see whether or not we need to adjust or change therapy. So how would you categorize patient B's behavior and emotional pattern? So if you take a look at the case, I'll go back here. All right, let me blow this up a little bit more to see. The patient, he has not had a good appetite lately, so he does not want to eat or drink, so this could lead to depression. He told one of the nurses that he does not deserve visits from his family anymore. He usually looks forward to afternoon because there's bingo activities, so he's very withdrawn. All right? And so if you take a look at his behavior, currently right now, he's on Seroquel for sleep. He's also, has diazepam, which we also know that could put somebody at a fall risk because it's a long-acting benzodiazepine. We know Seroquel is okay for maybe they're having psychosis. It's not an appropriate drug for sleep, and he doesn't warrant any antidepressant. He's also on Benadryl, which can cause a lot of anticholinergic issues. So one of the things we may want to think about whether or not we should be recommending an antidepressant for this patient. And so a good antidepressant to consider that can be used for patients with depression and also weight loss could be mirtazapine. Whoops, wrong Wrong slide there. All right. So, one of the things that we may think about in terms of the medical considerations of this patient, like I said, he's showing weight loss issues. He's having insomnia issues. All right. Also, making sure that none of his other issues such as pain, anxiety are contributing to that. There's numerous medications that can cause depression, so long-acting benzodiazepines could fall right into there. And we also know that he could be on some inappropriate drugs like the Benadryl. We know that, he is on long-acting benzo. He's maybe inappropriately on Seroquel. Another quality indicator is the incidence of cognitive decline. Numerous medications, due to especially with high anticholinergic activity, have been known to cause delirium because these drugs are very lipophilic. They can cross the blood-brain barrier, and because they're blocking cholinergic response, that can affect memory, that can cause confusion and cause delirium. So one of the things that we look at is, are they on any of these medications? Can we reduce these medications? Can we get rid of these medications? There's a theory out there, is what's called the anticholinergic burden, that somebody could be on one of these medications, not be a problem, but when you start adding 2 or 3 medications, that was where we see that confusion. We also want to make sure we work with the physicians and the staff to discern whether or not is this truly due to the medications, or is this person seeing cognitive decline due to dementia. Other quality indicators are the prevalence of bladder and bowel incontinence. All right, so for example, if our gentleman was showing bladder or bowel incontinence, one of the things that could be contributing to that is, the anticholinergics causing urinary retention. The prevalence of an indwelling catheter, that could be due to anticholinergics because the bladder is not able to contract. Prevalence of occasional frequent bladder incontinence without a toileting plan. Prevalence of fecal impaction. And prevalence of fecal compaction is considered a sentinel event. And the reason why it's considered a sentinel event is that the worst case scenario could be a perforated bowel. And if you notice, going back to our case here, is that he hasn't had a bowel movement in 3 days. And we do know that he is currently on an opioid medication. He is also currently on Benadryl, is highly anticholinergic, and those could be contributing to him not being able to have a bowel movement. So we might need to treat his constipation acutely for right now, but in the long term, look at what can we do for this patient. If he has to be on chronic pain meds, we may need to be thinking about adding something like a chronic stimulant laxative like Senna. Okay? If somebody's having urinary incontinence, you're going to have more detail about this next semester. So, but making sure, looking at the diapers analogy, is it because they have delirium, they just can't remember to go? Do they have a urinary tract infection? Should we treat that? Do they have an infection? If it's a female, do they have atrophic vaginitis, or if it's a male or a female, do they have urethritis that needs to be treated? Different pharmaceutical agents can cause either overflow incontinence or urge incontinence. Psychological factors can play into that. Excessive urine output, so are they on a diuretic, but maybe they don't need to be on a diuretic? Say they have urge incontinence and they're on hydrochlorothiazide. Could we treat their blood pressure with another agent? Restricted mobility and stool impaction. And so this resident here is having some constipation issues and also not really wanting to do much. And so some mobility issues in stool and treating constipation may also help with incontinence. The other thing is, lots of different drugs can cause constipation, and you had that talk several weeks ago. Just an example of what those drugs do and what they can cause. The other thing is looking at constipation. Different disease states can worsen constipation. Drugs can worsen constipation, and looking at always, can we eliminate or decrease the amount of drugs that cause constipation? Also looking at their lifestyle factors, their fiber intake, their fluid intake, their mobility. making sure that, if we have to refer them to the physician, if they're having severe issues, obviously nursing would be referring that to nursing care. Like I said, we can increase their fiber diet. That's great, but making sure that if you're going to increase their fiber diet, they have adequate fluid intake, because if they don't have adequate fluid intake, that can affect their that could actually fiber could actually worsen their constipation without adequate fluid intake, and making sure they need to go. There's numerous different laxatives to choose from. You did have that talk already, but like I said, we tried to avoid, good choices are osmotic laxatives, especially like Miralax, not many necessarily sorbitol or lactulose. Stimulant laxatives we like to reserve for acute, or if they're on like if they're on a chronic opioid. Bulk laxatives are okay, but they're not okay if the person doesn't have good fluid intake. And saline laxatives we try to avoid only for acute issues. Stool softeners, mineral oil, we avoid in elderly patients due to that it can cause a risk for aspirated pneumonia. And docusate sodium is an okay stool softener. You just have to make sure you take at least 200 milligrams a day. Another quality indicator that's looked at is the prevalence of urinary tract infections. Another quality indicator is the prevalence of 9 or more medications. So, prevalence of UTIs, obviously one of the things is this is more of a nursing care issue, that is the resin being wiped appropriately. If they're having numerous UTIs, do they have any type of, indwelling catheters? Is there any issues with urinary retention? And those should be, this one is more of a focus on nursing. Obviously, the prevalence of 9 or more meds. What are we making sure that with this prevalence is there an indication for the drug? Is the medication effective for the condition? Is the dosage correct? Are the directions correct? Are the directions practical? Is there truly an indication? And all those 10 questions I've gone through before through the MAI, because it's not necessarily how many drugs they're on. Are they on the right drugs? And that's our job as a consulting pharmacist. Other quality indicators focus on nutrition and eating, such as prevalence of weight loss, prevalence of tube feeding, prevalence of dehydration. So you've already had the talk on weight loss, but you know that the etiology can be anywhere from pathological, sociological, psychological, physiological, or medications. Different medications may affect weight loss, so we as consulting pharmacists should be evaluating those. The other thing is, in treatment of weight loss, we should also be looking at the drugs that we do treat for weight loss, because a lot of times those drugs may not be appropriate for that person. So for example, if I had a resident who is immobile, who's had a risk of clots, and they're not a cancer patient or a patient with HIV or AIDS, a drug like Megace, Magestro acetate, which can be used for weight loss, would not be an appropriate drug at this time for that resident. The other quality indicators are physical functioning, prevalence of fast residence, prevalence of decline of late loss ADLs, incidence of decline in range of motion. These a lot of times are going to be addressed by physical therapy, by occupational therapy, and by nursing care. The prevalence of antipsychotic use in the absence of psychotic and related conditions, the prevalence of anti-anxiety or hypnotic drugs, and the prevalence of hypnotic use two times in the last week. Obviously, this is our area that we need to be addressing. And one of the things that you will do on a monthly basis and look at on a quarterly basis, you'll be comparing the incidence of psychotropic use in that nursing home compared on a state level and a national level. And you'll be making sure that things such as that, if somebody's on an antipsychotic, does it have an appropriate indication for that antipsychotic? Because antipsychotics may provide benefits to help with severe and persistent symptoms such as hallucinations, paranoia, and delusions, but we try to avoid them, in patients with behavior issues who don't have true psych issues, because of the numerous side effects that go along with that. And so we're always having to assess whether or not these are appropriate for that resident. And a classic thing that you always ask yourself, are they a harm to themselves or a harm to somebody else. And that is where they may warrant antipsychotic use. So here's a listing of things that do not warrant, antipsychotic use, that are inappropriate. Just having anxiety, fidgetiness, nervousness, just, wandering around does not warrant an antipsychotic. And so the antipsychotic daily dose should not be equal to or greater than the maximum dose. And the daily dose, if it's greater than, if it's higher, it should be explained. And there are maybe a few times, maybe depending upon the resident, higher doses may be warranted. What should be done with antipsychotics? Antipsychotics should be, if they're on it for behavioral issues, there should be a tapering guideline for it. And basically, here's what is listed. If it's a dementia-related behavior, it should be twice in the first year and annually thereafter. If it's a true psychiatric condition, it should be twice in the first year to try to do a dose reduction and annually thereafter. If it's clinically contraindicated or you feel that it cannot be, then you should get psychiatry, whoever is prescribing that, to document that gradual dose reduction is not warranted at this time or it's failed, and then that'll meet the needs of the surveyors when they come in. Tapering guidelines for psychopharmacological medications. Medications include managed behaviors. We're making sure we're looking at other non-pharmacological issues to manage behaviors, stabilize mood, and like I said, we should be trying to taper these. And so there's a lot of different drugs that can be used in psychopharmacological medications that are not necessarily antipsychotics. And so what that means is sometimes we use drugs like Depakote, carbamazepine, gabapentin for behavioral issues, or like Lamictal, lamotrigine, that these should be also tried to be tapered over a period of time. Obviously, there's lots of, when we look at hypnotics also should be gradually dose reduced. One of the things, if somebody's using a hypnotic on a chronic basis, we should be looking at the various different agents that can cause insomnia. We should look at all the different causes of insomnia. And the guidelines for hypnotic use in an elderly resident, if they're going to use anything, it should be a short-acting benzodiazepine, used only when other possible causes of the resident's stress have been ruled out. And it should not exceed 4 continuous months unless an attempted gradual dose reduction has failed. The dose exceeded should not be unless higher. So what I mean by higher doses, please refer to references like Lexicomp. They list what the maximum geriatric dose is. So if it is greater than that, for example, Zolpidem, Ambien, the max dose in a geriatric patient is 5 milligrams. And so if it's above 5 milligrams, like they're on the 10 milligram or the 12.5 milligram CR, there should be documentation why the physician wants that. The other thing is, if the resident's taking the hypnotic greater than 2 times a week, then this should be documented why. And like I said, there should be a gradual dose reduction attempted. Anti-anxiety medications. Anti-anxiety medications can be used for general anxiety disorder, dementia of agitated states, panic disorders, and so there should be a document indication of why that anti-anxiety medication is being used. There should be an attempt for tapering, at least quarterly, for medications on with these drugs. And just like the antipsychotics and hypnotics, that if there's an issue, that should be documented appropriately for that. We should try to avoid long-acting benzodiazepines whenever possible. The only time that I would say a long-acting benzo is if they have other behavior issues. And if they're using a long-acting benzo, the one that I feel that's probably the safest out of all the long-acting benzos would be clonazepam. And the reason for that is it doesn't have any active metabolites. And like I said, if they're using it beyond 4 months, we should try to do an attempt of a gradual dose reduction. So we should be looking at these quarterly. There are some exemptions from restrictions. If you're using like diazepam for seizure disorders or tardive dyskinesia, or you're using clonazepam for tardive dyskinesia, seizure disorders, or restless leg syndrome, Nocturnal myoclonus is another name for that, or bipolar disorder. It just has to be documented in the chart. One of the nice things about a lot of the consulting software is that they have tools in there for you to keep track of when was the last time a dose reduction was done, when's the next time we should do that, and that you can keep record of all those things within your consulting software. Quality indicators number 22 and 23 is prevalence of daily physical restraints. This ties into behavioral issues, more of a nursing issue, but once again, you might get tied in, especially if they're on any drugs that could be causing delirium that's warranting a physical restraint. Presence of little or no activity. Obviously, there's an activities director in a nursing home, but at the same time, you could get pulled into this if there's issues with the other quality indicator, signs and symptoms of depression. And the last one we actually have next semester in the other geriatric course, we do have a section about pressure ulcers and wound ulcers that Dr. Anil will teach. But nursing always has to be looking at that residents just can't be sitting in one place. They have to be, if they are bedridden, that they're actually their bed is rotated to help prevent the development of pressure ulcers. And treatments. We'll go in more detail next semester, but whether or not they need any type of anti-infection drugs, debridement, and appropriately treated for wound care. And so here's just a listing of different topical antibiotics that can be used for wound care and some comments of their usage. Key points to consider when looking at quality indicators, we're still tying those into our regular consultant review of a resident. So should we always be looking at assessing any changes in labs, vital signs, history of medication responses to appropriately take care of that resident. Obviously, we should be looking as a consulting pharmacist the total number of meds, make sure each thing has an indication, the appropriate dosing of those. The use of as needed medication. So, for example, if a patient is in pain and they're acting out on with behavioral issues, look at their PRN usage. Maybe they need a chronic pain med versus a PRN med. So this is the talk on quality indicators. What we'll do next week, I'll actually bring up that case. So take a look at this case number 75. We're going to talk about that other nursing home case pretty much predominantly throughout our talk, but I'll bring up this case too. So just take a look at it and see what you think about it. All right. Thank you very much, and I'll talk to you next week.